Good evening, everybody. So this is welcome to fourth session of GLAD. The GLAD is Gastroenterology Liver Academic Discussion Forum. So this is a physician-oriented program, and till date we have covered jaundice, ascites, and the next most common is today we are going to approach to the GERD, that is gastroesophageal reflux disease. So Professor S.C. Anand, who is the head, and Professor Department of Gastroenterology Hepatology at KIMS Bhubaneswar, and also he is the chief editor of JCS, the Journal of Inasal. And sir is kind enough to go today in a very interactive way. That is, we'll go by the common questions you are facing, the problems you are facing in diagnosis, managing the GERD, and at the same time, we'll request you to share your questions or views or suggestions for the discussion to be done in the chat box. And to honor us, Professor Subrat Acharya, who needs no introduction, sir is there. Professor Akash Shukla is head of the Department Gastroenterology and Hepatology at KM Mumbai, and Dr. Bedi Goswami, who is Dispur Hospital from Guwahati, are being in the board for the moderation of the sessions. And now I request Professor S. Anand to carry for next couple of minutes on this important topic. Thank you, sir.
So, Professor Acharya, sir, would you like to make an introductory comment on gastroesophageal reflux before I present the cases?
I think you should present, but to start the ball rolling, I can tell you, and if the physicians are attending it, it is almost everybody's experience and one of the most common problems that a general practitioner, a physician, a gastroenterologist, a surgeon faces in everyday practice of his life. Despite the fact that gastroesophageal reflux disease is a complex problem, as people think it is not a simple problem. It is actually abnormality of various substances, starting from esophageal mucosal defense, contractibility, the pressure in the lower esophageal sphincter, the amount of acid inside the stomach, their duration of reflux, and the ability to cause injury, and the duration of such refluxes. There are many issues on this disease, which are quite complex, and it can compromise both with quality, and people may not believe it can have actually sinister complications sometimes associated with it. And therefore, it should not be ignored. And while it is being treated, it is also treated casually. And a very casual long-term treatment with various drugs, which are given usually thinking they are very safe, not necessarily very safe as well. And there are certain basic points which are very important for people to know. And even a gastroenterologist, we are not knowing many aspects of it. And I don't think there will be a better person, a more cerebral person, or more knowledgeable person, or person with better insight than General Professor Anil Chandra Anand, whom I think has the best brain in the country to dissect, analyze, and make it very lucid for all of us. General Anand, please.
Thank you, sir. I know it is your affection speaking because I'm your student. I will start by sharing my screen. And what I'm showing you here are two cases with heartburn. That is the title of presentation, I'm going to take help from these two cases in talking about the management of gastroesophageal reflux disease, both at the primary and secondary level of care. I am not going to talk about tertiary level of care because that becomes very, very complex and it may not be possible to cover everything within a period of 1 hour. So let me begin with the two cases. Let me begin by saying that Mr. and Mrs. Saxena are real patients. However, the picture that I've shown on the screen is a representative image and that does not belong to the actual patient. Mr. and Mrs. Saxena are 52 and 46 years old, respectively. Both have been having heartburn and sour eruptions off and on for about 1 decade. And they always had antacid bottle on their dining table and they used it ad lib. Whenever they felt heartburn, they took antacid tablets. But for last few years, the symptoms were becoming more troublesome, and that is why they consulted their local physician. Now, before I go to discuss this problem further, I will have 3 basic questions about heartburn and gastroesophageal reflux disease, and we'll quickly cover those and then go on with the case. Firstly, what is the prevalence of heartburn or GERD? So, Ashok, would you like to answer that? There have been 3 prevalence studies which have been carried out, and they have found that overall prevalence was 8.2 in Tamil Nadu, 22.2 in Kerala, and 18.7 in Ladakh. And it is almost, incidence is double in the urban areas as compared to the rural areas. So basically 7.6 to 30% of Indian subjects have symptoms of heartburn. And it has been found that non-vegetarian food is an independent predictor of gastroesophageal reflux disease. BMI has similar, was the studies that have been published by Indian people, they have shown that obese and non-obese people have similar prevalence of GERD symptoms. As per other studies, the incidence is little higher and about 30 to 80% among asthmatics. That was the first question about the prevalence. Second question is, what are the predisposing factors? Would you like to talk about it, Ashok?
Yes, sir. The predisposing, the most common is the our dietary habits, we can say. And then, as you have rightly mentioned, the lifestyle problems, all we have taken into group, that is obesity, smoking, and particularly diets which decrease gastric motility like coffee, fatty foods. And also you have mentioned here also rightly the H. pylori infection. So these are the lifestyle related. Then some other diseases are also there, like collagen vascular disease, we get scleroderma. Then another important thing is that alcohol, which we very often also associated with. And fourth one important is our dietary habit, that we take too much of foods at a time. And another important is we call the hiatus hernia, which is a commonly endoscopic finding. So this we can combine. One is, I think, sir, you must have grouped into good way for the presentations. So these we can combine as the predisposing factors.
Very true. The obesity has a odds ratio of 2.16. That means obese people probably have double the amount of gastroesophageal reflux as compared to non-obese, although this has not been confirmed in the Indian studies. But this is the world over, people have believed this. Smoking also increases the incidence of gastroesophageal reflux. The evidence in favor and against alcohol is equivocal. We really do not fully know, although it is strongly suspected that people who take alcohol also have higher chances of having GERD. But evidence has not proven it yet. In the diet, there are many variables, and meat has been found to be increasing the incidence of gastroesophageal reflux disease in Indian studies. tea, coffee, chocolates are strongly suspected to increase the incidence. Oily food also is strongly suspected to increase the incidence, although Indian studies have not really shown that so far. There is a Korean study which has shown that GERD is almost twice as common in people who are not infected with H. pylori. In fact, H. pylori incidence may have some protective effect against the GERD. What symptoms we should look for if we suspect GERD? One is, of course, heartburn and sour eructations, with both Mr. and Mrs. Saxena had. What other symptoms can be there? Ashok, you are the only one who has to answer. So I'll just show the slide also.
Yes. So as you have rightly mentioned here, so I think most commonly we got the called as the heartburn or the regurgitation. We get sour taste in our mouth. So these are the common things. Then very often we get a chest pain, which confuses with coronary symptoms, dry, long-standing, non-productive coughs for a longer duration of time, and also sometimes you get a hoarseness of voice and dental erosions, as you have mentioned here. So they are the very much common things. But a common presentation what often they comes to us is that they're having a heartburn. They're getting like some symptoms of having heart-related ailments, and they get a dry cough or they get sour taste in the mouth. This is the most commonly, and other things like cough, sore throat, dental erosions, that is a physician elicits in a history by giving leading questions to the patients. So that the common things we get in the GERD.
So people also suspect that sinusitis, pulmonary fibrosis, otitis media, and even IBS is associated with the heartburn and GERD. But these associations are not evidence-based. The evidence-based associations are limited to laryngitis, asthma, dental erosions, and sleep disturbances. So let's move on to the cases then. Now, Mr. Saxena, when they consulted the physician, realized that Mr. Saxena is a known case of bronchial asthma and hypertension on treatment. And therefore, the physician prescribed Pentocid DSR and advised the patient to reduce weight because both of them were a little overweight and obese. Symptoms responded within a few days. That means in a period of about 2 weeks, patient's symptoms disappeared. On the other hand, Mrs. Saxena, who was a known case of diabetes and hypertension and did not have any asthma, physician prescribed same medicines, that is Pentocid DSR, and advised to reduce weight. Her symptoms became less for a few days, 3-4 days, but then recurred with the same vigor within 15 days' time. So in a way, Mr. Saxena responded, and Mrs. Saxena did not respond to the Pentocid DSR that was given. So here I like to ask a few more questions. First is, what is the relationship between asthma and GERD? Would you like to talk about this?
It's a little bit, sir. But as we rightly said that GERD often leads to the reflux, then laryngeal, and also trickling down. So there can be a trigger for the bronchial asthma. At the similar time, we are taking also it can be coexistent also. When you take the bronchodilators as inhalation also, we get also reflux symptoms because of the steroids and other things. So both are interrelated, sir. And
in India, they have found that nearly half to 70% of asthmatics have associated GERD. These are Indian studies. But patients are symptomatic usually with heartburn. Only about 1/3 of the patients may have silent reflux and may not have symptoms of heartburn. But when you do an endoscopy, you realize that there are erosions in the esophagus, which are suggestive of a gastroesophageal reflux disease. in difficult to treat asthma, it is recommended, and also patients with chronic cough, especially which is non-seasonal, we should evaluate these patients for reflux disease, because this could be the silent trigger and this could be the cause of non-response to regular treatment in asthma. So this is one question that is there, a relationship between asthma and gastroesophageal reflux disease. Now, second question that I want to ask is, was this treatment given by a physician correct? And there are three sub-questions to that, should physicians have asked for endoscopy at this stage? What lifestyle changes he should have advised apart from weight loss? And is the drug treatment given by him correct? What is your take on that, Dr. Chaudhary?
Sir, first of all, endoscopy is needed, but being as a physician, when we are seeing the patients, is very difficult to advise them. If you are advised to get it done, also is difficult. So in that case, we can go by we have mentioned PPI test. So this can give the PPIs, and then we can get the resolution of symptoms, which retrospectively establish the diagnosis of having GERD. And if he is non-responding, then we can think in the line of having to go for a endoscopy. So what I can suggest that if as a physician, if we are very much sure by the history about the diagnosis of GERD, then they can advise a PPI which is easily available and they can prescribe very often. And then they can follow up after 1 to 2 weeks for this. And if it is referred, as you have mentioned the second case, then they may be need for a endoscopy or further evaluations which are not elicited at the initial point of time.
I agree with you. Most physicians would apply a PPI test, but the studies have shown that this test has a sensitivity only of about 80%, and specificity is still poorer, that is about 74%. So even if the patient has responded to PPI, only 74% of them would have been responding as a GERD patient. The other patients may be responding as a placebo. When you give any medicines to a patient who does not have GERD and still has heartburn, and we'll talk about it a little later, the 25% or 30% people would respond as a placebo. Any drug you give, they will respond. So PPI test is usually employed in general practice, but we must realize that this is not a foolproof test. It can go wrong both ways, in sensitivity as well as specificity. And therefore, there are certain situations where endoscopy must be done upfront. In this case also, we'll see what happens later. But the indications for endoscopy when a patient comes with reflux diseases, if the patient has associated dysphagia, if the patient has odynophagia, if the patient has iron deficiency anemia in addition to GERD, if the patient has progressive weight loss, if the patient has new onset of atypical symptoms at the age 45, 55 or above. In certain countries, they recommend 55 and above. In certain countries, they recommend 45 and above. It will depend on what is the physician's assessment of the patient, whether he suspects that there can be anything serious in this patient or not. So you can recommend endoscopy if the patient comes for first time with new onset heartburn after the age of 45 years. If there is poor response to antibiotics, as Dr. Chaudhary has already said, and there are long-standing symptoms which are not responding very adequately. If there are complications are suggested, for example, if there is a peptic stricture or Barrett's esophagus or GI bleeding, and in this situation, definitely endoscopy has to be done upfront. What do we see in endoscopy report? Because patient will come with endoscopy report to a physician. So what would you advise a general physician to look at in the endoscopy report, Dr. Chaudhary? You can unmute yourself. Kindly unmute yourself.
Yeah. Sir, already you have mentioned here. The first one is the hyperthermia we see. Then esophageal mucosal changes, erosions, ulcerations, stricture formations, constriction rings, and these are there. Then sometimes we get the tears also. And when we another yard is the Barrett, the changes, the short segment Barrett or long segment Barrett's. And is there any changes, particularly what you told that in the elderly new onset? When an elderly with a new onset, you should think in the line of having a G junction malignancy also. Then fourth, another important is the gastric motility disorders, where we can find secondary achalasia like that symptoms. Even also primary achalasia, we will get reflux, but is very less. They come also with dysphagia. But so these are the things we have to see in a group from esophagus to the G junction as far as esophagus and stomach is concerned. Then another is that you can see the reflux because of the lower down. The stomach related issues, gastroparesis, gastric outlet obstruction, they can also part of this process. So you will get all these symptoms from esophagus till the stomach to be examined. And you can see that has been mentioned by the endoscopist in the report.
Yes, I'll repeat that. Important things are, there are three things that a physician must look at because this may have implications on future treatment. One is the presence of ulcerations or erosions in the lower esophagus. Second is presence or absence of hiatus hernia. And third is presence or absence of Barrett's esophagus. So let's move forward from here. What lifestyle measures should be recommended and what are evidence-based? Would you like to answer that, Dr. Ashok Chaudhary?
Yeah, so as you rightly said, most important is the diet. Already you have mentioned as the risk factors. So diets, smoking, and then our food habits, particularly diet-related food habits, and then some drugs which are causing these factors also. So these are the common things.
Okay, there are a large number of lifestyle measures which are described in the textbooks, and they are described because of the traditional knowledge and pathophysiology that we understand. What are the things that cause relaxation of the lower esophageal sphincter, and it can cause reflux of the acid into the esophagus. In diet, there are many things which relax the lower esophageal sphincter, and they include citrus fruits, tomatoes, coffee, cola, alcohol, chocolate, peppermint. We also advise them to take less amount of fat and spices and more protein. And small frequent meals are advised because large meal will increase the intra-abdominal pressure, and that would also favor the reflux from stomach into the esophagus. We should advise the patient to decrease or totally stop smoking. Patient should sleep with the elevated head end of the bed by about 6 inches and sleep on the left side, but do not lie down for 2 to 3 hours after eating. Now, elevated head end of the bed by 6 inches is shown in the red color, and there is an asterisk mark on it because there are studies to demonstrate that this is an evidence-based recommendation. The rest of the recommendations are also effective in the practice, but no studies have been carried out. Clinical studies have been carried out about them. Other modifications are to avoid tight clothing, avoid straining or lifting heavy weight, avoid exercise after meals, and lose weight to come near the ideal weight if the patient is overweight. And there are several drugs which can increase gastroesophageal reflux, and some of common ones are mentioned here. One is alendronate, theophylline, especially given for the asthma treatment, nitrates, anticholinergics, calcium channel blockers given for hypertension, prostaglandins, oral contraceptives, and beta-2 blockers. The next question is, patient was treated with Pentosid DSR. Do you feel that treatment was correct, Dr. Ashok Chaudhary?
Yes, sir. We have discussed in the line of PPI test that way. So it is to be given. and it contains two drugs. One is acid suppressant, another one is having the anti-reflux or the prokinetic agent. So that's why it depends upon the severity. But as you rightly said, initially it should be started with PPI alone to see that acid has been suppressed and the reflux is because acid has gone down. So that is the first. And DSR should be given only in selected cases. So it should be initially the plain, as you mentioned, the PPI test, we can say.
The drugs that are commonly used to treat reflux are shown on the your left side of the slide. They are omeprazole, lansoprazole, pantoprazole, esomeprazole, reviprazole, ilaprazole, and dexlansoprazole. All of them are equally effective. There is no choice that one is more effective than others, and their equivalent doses are shown in the chart here. Usually a single dose of omeprazole, 20 milligrams in the morning, is what is usually recommended for these patients, and this is included in our ISG API guidelines as well. Now, it is recommended in the guidelines that the domperidone or prokinetics are not really, should not be used for treatment of gastroesophageal reflux. And why, we will talk about it a little later. There are several other drugs also in use, which also we'll talk about later, but let's move forward and see what happened to Mr. Saxena. Now I'm separating Mr. and Mrs. Saxena here because we want to discuss them separately because they responded separately. First is Mr. Saxena continued treatment for about 8 weeks and remained well. The day treatment was stopped, the symptoms recurred. He was now given double dose treatment of PPI and again responded, but symptoms relapsed again on stopping. So should we call him that he's dependent on PPI? And the next question that I want to ask is, PPIs have numerous side effects when given on long term, and how should we de-escalate PPI? Dr. Chaudhary, would you like to attempt that?
Dr. Anand, Professor Akash
Is Dr. Akash Shukla also online?
Yeah.
I see his name on the list.
Yes, sir. Good evening.
Good evening. Would you like to take this topic? What are the common side effects of long-term PPI and how to de-escalate?
So basically, all the PPIs with almost 20 years of usage, almost 1% of the patients will have side effects. The ones which have been described commonly are B12 deficiency, osteoporosis, renal dysfunction, and rarely cardiac side effects and arrhythmias. So those are the pooled together. Around 1% of patients will have these disorders. And therefore, it is always best to de-escalate the PPIs to the minimum dose that is required. And wherever possible, we can stop the PPIs. Now, there is no standard regimen as to what, how we de-escalate. And therefore, we all have our own ways of de-escalating. But what we do usually is those who are on twice a day PPIs, we would want to get them to once a day. And then once they are on once a day, then you keep on reducing the dose. So if they are on, let's say, 40 milligrams of pantoprazole, then you get them down to 20 milligrams of pantoprazole for around 2 to 4 weeks. And then you keep on reducing the frequency. We can try making it alternate day and then stop. We do not stop suddenly because there is a phenomenon of rebound increased acid secretion, which has been well described for the first 2 to 4 weeks, which makes the people go back to taking the PPIs. So that is why it is always to gradually taper off the PPIs, especially those who have taken it for substantial period of time, and avoid these long-term side effects.
I think you covered it very well. And I'd just like to mention that there has been a complicated guidelines issued even by the Association of Physicians of India as to how to de-escalate PPI in patients who have been taking it for a long term. But Dr. Akash Shukla has summarized it in a very, very simple manner, that first you reduce the dose, then you can replace, if you are unable to reduce the dose from twice a day to once a day, then you at least reduce the dose on one side. That is, if you are taking 40 milligram twice a day, then evening dose of 40 milligram should be replaced by a H2 receptor antagonist. And gradually we should try and wean off from PPI and switch to H2 receptor antagonist. And that can also gradually be tapered off. And he said very rightly, if you suddenly stop, it can cause rebound increase in acidity and the symptoms are bound to come back. But the question I want to ask now is, how long is it safe to give PPI? Mother, what is recommended? How long we should give PPI? Dr. Akash Shukla, would you like to say?
So usually for most patients of gastroesophageal reflux disease, what is recommended is 8 weeks is what is the usual duration. Some people would give up to 12 weeks and then try to taper. For other indications like duodenal ulcer or gastric ulcer, we would usually give for around 6 to 8 weeks. And but if we have not treated the cause of the duodenal ulcer or gastric ulcer, or if the patient is being continued on NSAIDs, which are ulcerogenic and are unavoidable, then in those people, they have to be continued long term till the NSAIDs are continued. So those are the three situations where you would use. For those patients where we are giving PPI for H. pylori eradication, usually it is for 6 weeks. We give the PPI, 2 weeks of antibiotic therapy, and then around 6 weeks of H. pylori therapy. And after that, we would usually stop. What happens is most people are afraid to stop PPIs when they're giving H. pylori therapy. And this is one of the commonest reasons why people continue to take long-term PPI despite H. pylori eradication.
Excellent. So PPI, as far as possible, we should try to reduce it to 8 to 12 weeks. There are three situations where we give it to the on the long term. One is the Barrett's. Second one is as long as the NSAIDs are required in fairly high dose, and finally Zollinger-Ellison syndrome if the surgery is not being offered. Now we have Mr. Saxena to deal with. He shows that PPI works in him, but patient cannot be weaned off. So does he require anti-reflux surgery or endoscopic treatment? These are the next two questions that we are going to discuss. And Dr. Chaudhary, what is your take on that?
Yeah, so first of all, when they're not responding to PPI or the relapse of the symptoms when the PPI is off, they're difficult to treat. So here, definitely we need the treatment, but here we have to go for a few studies as we do for the pH study among the reflux related, and then we have to see the other associated adversarial factors like weight loss and dietary compliances and the life related problems has been addressed or no. If all these things have been adequately addressed or because of limitation they cannot able to go for, then we can go for this. And till date surgical therapies no doubt has come up, and now the endoscopic treatments are coming up for this mucosal healing and injury prevention, ARMA. And also if it is hyperthermia or something like that, then plications are there. Both surgically is still established and endoscopy also now it is coming up.
Yes, Ashok, you're right. One thing I want to say in this slide is that surgical treatment is effective for control of GERD. That is one thing. Only thing is surgical treatment is not recommended in patients who are not responding to PPI therapy, because the mechanism of action will be almost similar. And second thing which I like to add here is that surgical treatment is not indicated in people who have symptoms but no ulcerative esophagitis. If there is no ulcerative esophagitis, then we cannot really give surgical treatment, because surgical treatment is given only for organic heartburn and not for functional heartburn. So let's move forward and see what happens with the problem in Mr. Saxena has been that PPI test can diagnose GERD. I told you that sensitivity is about 80% and specificity is 74%. But the question is, did this patient have GERD in the beginning? Because endoscopy done now is normal. So this patient was subjected to endoscopy. It was found to be normal. But we really do not know that 8 weeks back when he started symptoms, did he have erosive esophagitis or not? Because if he had erosive esophagitis as the primary disease and he is relapsing on stopping PPI, then he would benefit from surgery. But suppose he did not have erosive esophagitis right from beginning and he has a functional heartburn. In that case, the surgery will not be of much use. Therefore, one needs to prove that patient had erosive GERD. The option has been lost in Mr. Saxena as the endoscopy was not done initially, and the normal endoscopy could be because of healing caused by PPI. Therefore, there is a need to prove that acid reflux is the cause of symptoms. And this can be done by preoperative ambulatory pH monitoring, which is now mandatory in a case like this, who does not have evidence of erosive esophagitis. So we have to prove that the symptoms are caused by acid reflux. And for that, we do a test called pH monitoring. pH monitoring is usually done by a capsule which is attached to lower end of esophagus, or through a catheter, a probe is passed into the lower end of esophagus. And we then monitor like a Holter monitoring for 24 to 48 hours, what are the episodes in which the esophageal pH drops below 4, that it becomes highly acidic. And if the esophageal pH is constantly above 4, then this patient does not really have acid reflux. This patient may just be having either esophageal hypersensitivity or a functional heartburn. And therefore, this can occur because of acid inhibition, that is due to PPI therapy, absence of acid secretion, autoimmune gastritis, misplacement of pH probe, and all these things we have to check and look at the pH monitoring report. And repeat pH monitoring or performing other complementary tests like taking gastric biopsy sample may be useful in some of these cases. So what do we do? How do we interpret these findings? If the test is done off PPI and if the test is done on PPI. Because as soon as you stop the PPI in this patient, he starts having severe heartburn. And therefore, you can't really withdraw PPI in this case. And therefore, what you do is you stop PPI for a few days and then you do the test of medications. And if there is an abnormal reflux burden, then we call it a gastroesophageal reflux disease, and the patient may really benefit from the reflux surgery. But if there is a normal reflux burden, but positive symptom association, then we call it a reflux hypersensitivity. That is, esophageal mucosa has become hypersensitive. But if there is a normal reflux and negative symptom association, that means whenever the pH goes down, the symptoms do not occur. But when the symptoms occur, the pH does not go down. In this case, we can call this as no GERD, and this may be due to functional heartburn or an alternative diagnosis like rumination, supragastric belching, or eosinophilic gastritis. So this is what we need to do at this stage when the patient is having trouble weaning off PPI. So this was done for this patient. We'll talk about what happened subsequently. In this case, we really found that it was the reflux which was causing symptoms of the patient. And therefore, Mr. Saxena was referred for reflux surgery, and he underwent reflux surgery, and it required a few weeks' time before his symptoms gradually started going away. Second patient was Mrs. Saxena. She was also offered double dose of PPI. There was again a small temporary response for a few days, but symptoms did not go away. So the question here is, does she have refractory GERD? And therefore, in this case also, endoscopy was done. And endoscopy was found to be normal. Now, in this case, patient is not responding to treatment, still symptomatic, and the endoscopy is normal. So can we call it that she has a refractory GERD? What is your opinion, Dr. Shukla?
I think we need to study the.
Shukla is not there, Dr. Chaudhary.
Before telling. Yeah. So, yeah, I have mentioned already that causes for this, but in this also we need to go for a PS study as I mentioned here, and an endoscopy before telling it as refractory GERD. And these are the causes we have to look for.
So refractory GERD, when clinically it appears that patient is not responding to PPI, there can be two reasons. One is on endoscopy, you find persistent esophagitis, which we did not find in this case. But if there is a persistent esophagitis, then probably the dosing is poor or the compliance is poor. There is reduced bioavailability in that particular individual. Pharmacogenetics is playing its role and not allowing the drug to be effective. Or there is a bile acid reflux which is causing the ulcerations. There may be a nocturnal acid breakthrough. That means most of the PPI have a half-life of 10 to 16 hours. And therefore, late in the night, if you take the dose in the morning, late in the night, the effect of PPI wears off and there is a nocturnal acid breakthrough. And for this, we have a delayed release or a dual release PPI available. If there is an NSAID misuse along with it, or there is a hypersecretion as in Zollinger-Ellison syndrome, and people have mentioned PPI resistance, which has never been documented so far. So this actually does not occur. But if the patient does not have, there is a symptomatic failure and endoscopy is normal, then we can have a patient having functional heartburn or esophageal hypersensitivity. There can be weak acid or alkaline reflux. There can be psychological comorbidity, which is making the patient symptomatic. That is, there is a somatization of the psychological problems. And there can be presence of undiagnosed achalasia, pill esophagitis, herpes, candida, eosinophilic esophagitis, and delayed gastric emptying. And these are the other situations where sometimes the patient will continue to have symptoms even when the esophagus appears normal. So if Mrs. Esophagitis had erosive gastritis, then we would have thought that possibly there is need to optimize the PPI therapy. Add a nighttime H2 receptor antagonist, antacids. There is additional evaluation would have been required as to what is causing these problems, and we would have tried to add some other drugs. For example, baclofen is used in this situation, which reduces the temporary GERD, that is, temporary reflux of acidic contents into the esophagus. Other drugs which have been tried in this situation are tegaserod, tenetoprazole, and patients with normal tests, sometimes SSRI and trazodone also works. Now, here I'll come back to the point that we discussed earlier, that DSR, the domperidone and other prokinetics like levosulpride and etopride, they work only on the stomach and they don't work on the GE junction. Therefore, for a normal GERD, the domperidone and all are not required. But if the patient has delayed gastric emptying, that is the situation when the prokinetics will be useful. For example, a diabetic patient who has delayed gastric emptying because of autonomic neuropathy. Now, in that situation, domperidone or levosulpride can help. But if the patient does not have delayed gastric emptying, then prokinetics are not recommended. Now, question is, in her case, are the symptoms due to reflux? And for that, again, a pH metry was done, and we found that her acid exposure time was not really more than 6%. This is to decide whether symptoms are the cause of reflux or not. Reflux is the cause of symptoms or not. We do a pH metry test or an ambulatory test. Acid exposure time should be more than 6% to say that acid is the cause of symptoms. And the symptom index, the percentage of symptom events related to reflux episode, is pathological if there are more than 50%. But symptoms association probability is a statistical parameter which is corresponding to the Fisher's exact test, exploring the strength of relationship between symptoms and reflux, and it is pathological if it is more than 95%. This is a statistical test which is given by the computer which is attached to the pH metry test. And if the SAP is more than 95%, then you can be sure that symptoms are caused by reflux. In the case of Mrs. Saxena, it was not really found so. This is how the impedance test is done. Impedance basically is to find out how much liquid is there, which is a good conductor of electricity in the esophagus. And if the impedance is found to be low, that means that there is fluid in and it may be a low acid fluid even if the pH metry has not shown pH drop below 4 degrees. I'm not going to discuss impedance because it will become too much for a general physician. Therefore, I'll just like to say that Mrs. Saxena underwent 48 hours pH recording, and her esophageal acid exposure on day 1 and 2 was 1.2 and 2.7%, which is much lower than the 6% threshold which is there. And it was during the day and during postprandial periods that this occurs, which is a normal phenomenon. In normal people also this can happen. She experienced heartburn on 27 occasions during the day, and symptom association was found in only 36%, which is less than 50%, and therefore will not call that acid reflux is the cause of symptoms. And therefore, she was diagnosed as a functional heartburn. And for functional heartburn, generally we prescribe tricyclic antidepressants or SSRIs or SNRIs or trazodone. In this case, she was given imipramine 25 milligrams a day, and she responded within 6 weeks, and her symptoms of heartburn totally disappeared. So I like to summarize the whole thing that we have talked about. One is, if you find a conclusive evidence of pathological reflux, this is on pH metry, it is confirmed, and in these cases, generally, PPI would be effective and should be prescribed. On the other hand, if you find borderline or inconclusive evidence or adjunctive supportive evidence showing that there is a evidence of reflux, but even the pH is not going below 4, even those patients is going to respond, and this can occur because of hypotensive esophagogastric junction, where baclofen can help, hiatus hernia is present, or esophageal hypomotility is present. If there is no total absence of pathological reflux, in which the acid exposure time is less than 5% and reflux episodes are less than 40, then we can call it a functional heartburn, and these people will respond to the tricyclics or SSRIs. Now, this is all that I have to say. If there are any questions coming from the audience, we'd like to answer them.
Thank you, sir, for your nice the systematic approach and elaborations. So I think Dr. Manjunath has asked, is there any new endoscopic treatment for the GERD? Can you guide, sir? Dr. Anand? New endoscopic treatment for the GERD?
GERD current treatment is so effective that you don't really need new endoscopy, new treatment. Although there are stronger acid suppressive agents are now coming, longer action is there. There is a dual dose escalation is there, and there are delayed release formulations are there. Sometimes you have 80 milligram of Antosig being prescribed. This is basically for the late night breakthrough acid reflux. So I don't think a new higher, stronger PPI is required at present, because PPI resistance is not really known to be present. It's never been documented. Akash, you have any thoughts on this? Okay, Ashok, would you like to add anything?
No, sir, I'm agreed with you. Sir, one more suggestion there for the patients of post, I think this we can ask to Professor Akash Shukla. So there is post-bariatric surgery GERD symptoms. So how to manage them medically or any endoscopy or anything? Professor Akash?
So honestly speaking, I am not the expert. I leave this question to Dr. Anand only. I have not really handled this. So I think it is unfair of me to answer this question.
The medical treatment of post-bariatric surgery GE reflux remains the same. It doesn't change much. But if the bariatric surgery has led to any other problem, that can be resolved if the hiatus hernia has occurred, or if there is a widening of the, because of the dissolution of fat, sometimes the esophageal, the diaphragmatic opening becomes a little wider, and there can be a reflux of the whole gastric, the whole stomach can go up into the chest, and those symptoms can be separately addressed by surgical treatment. Dr. Acharya sir, would you like to say anything on this?
You see, there are various types of bariatric surgery. What Dr. Ashok Chaudhary is referring to actually is complete, has not sleeve gastrectomy, but gastrectomy with a bypass bariatric surgery, where intestine, a gastric remnant is left, and intestine is attached almost to the gastric remnant. Am I right, Ashok?
Yes.
Hello? Hello?
Yes, sir. Yes, sir.
Ashok agrees with you, sir.
Yeah.
You see, in
Yes, sir.
that case also, this is invariably an alkaline gastritis, right? Because you have removed the most portion of the gastric and only small portion of the fundus is left. So predominantly it is a bile-induced reflux. As Dr. Anand has already pointed out, that non-PPI responder, one of the causes is actually a duodeноgastric reflux, and alkaline gastritis is also another big problem, right? Which is treated with PPI with the opposite effect, right? So that is a variant which is there, which has to be taken care of. But in sleeve resection, invariably you will not get a lot of reflux associated disease. It is because of nowadays more often the bypass surgery is done with gastrectomy. We get this reflux problem along with nutritional deficiency, which is a different ballgame. And General Anand, I would like to comment also. You have given excellent disposition, but one very simple thing which helps most of these patients is a positional place, because positional place, head and raised, sleeping on the left lateral side.
I talked about it.
Yes, particularly reflux occur mostly in the night, right? But when the gravity effect is lost, and if you simply ask the person to raise his head and turn on the left-hand side, right? That is one thing I want to say. Second, it is the balance between intragastric pressure, lower esophageal sphincter pressure, and esophageal pressure. So decreasing the amount of food right? Decreasing the intragastric pressure, right? You see, is another important thing. You cannot have randomized controlled trial or evidence.
That is what I said. This is recommended to have small, frequent meals,
right?
And not wear tight belts over the abdomen.
That's very important.
Wear tight clothes.
Those very simple measures. Right. And third thing, when you are causing about de-escalation, right? Most often the reflux occur when you are sleeping because the gravitational force is not there. So in contrast to morning dose of PPI, right, when you're de-escalating, right, a H2 blocker at the bedtime in the process of de-escalating, because patient's compliance is very important, right? And there are certain other things which I don't want to go into the details, right? Because in a real life scenario, when you are dealing with general practitioners doing a pH metry, right? Ambulatory pH metry over 24 hours, right? Documenting more than 6% in a population where about 30% have GERD, because your sample size which you have presented, right, is not representative, sir. Right. So 30% is a Herculean task. So we have to provide a very simplistic real life situation. And this positional dietary modification and de-escalation, big problem, remember, all general physician you are using for dyspepsia, for IBS, for non-specific symptoms, PPI at random. And PPI is the highest drug which is sold across the counter, right, in the country and in the world. Everybody pops up a pill of PPI in the morning and he's psychologically hooked. He says, unless I take it, I don't.
Gas ka goli khana zaruri hai.
Gas ki goli khana zaruri hai. This is a myth. And this myth has to be, right, removed. That's all my comment, nothing else, because it's a very common disease. And that's what I thought. I will let you know that positional change and dietary modification is very important.
Actually, if we take about 100 cases who present to us with heartburn, surgery would be required in less than 1%. This is what
that's
my
right.
experience
and that's a very important thing General Anand told. You see, general physician must understand, and keeping a situation in our country, I am normally very blatant and blunt, right? Endoscopic, right? Fundoplication, endoscopic suturing, endoscopic stitch will be practiced extensively. It is not needed as general Anand. Most. So therefore, one must be very careful. There are hundreds of reversible factors for such symptoms. And General Anand has pointed out, if you see the proportion of patients who have functional symptoms of heartburn is quite large. And therefore, it is very important to understand this aspect.
So this is exactly why aim was to highlight that in one family, there are two patients with heartburn. Yeah. One has a real reflux. The other one has a functional heartburn. So right. Functional heartburn is equally important and equally troubling to the patient.
Yes.
But the treatment is different.
You have to understand.
Sir, one of my suggestions. Yes, sir. Sir, one more suggestion, sir. It is a basic instinct to write the PPI. As you rightly said, any complaint related to GI symptoms, PPI is there. So my suggestion, sir, is that, sir, do you suggest anything about the dinner? We suggest that the early light dinner. Yeah,
that is well known. That is there in your culture. You have changed it.
It is actually recommended that you should have at least 2 to 3 hours gap between eating and lying down.
That's right. That's right. They have dinner before 7.
Should be little bit light. Yeah.
Light and before 7 p.m. That's the fundamental.
Yes.
Thank you.
Any other question?
Yes, sir. So, and I think I have less questions regarding this. Now, one more question is about PPIs. You tell that all are equal. So, which one to prefer? If physician comes with the brackets of all PPIs are available to him to give, so which one to prefer? Then when to go for a twice daily dosing, because they know that it is having the long acting action.
The PPI should be given which is the cheapest.
Okay.
Because a Rebiprazole tablet is also available for 2 rupees and it is also available for 80 rupees. So there is no point in giving 80 rupees tablet when a 2 rupees tablet will also work. All right. So one is it should be cheapest. And second is the dose escalation to higher dose is only required if the patient's ulcers are not healing at 8 weeks. Presence of symptoms alone does not really prove that PPI is not working because patient may be having functional heartburn.
Okay. So what is the role
of the patient has not responded to 8 weeks of treatment and you do an endoscopy and find ulcers are there, that is the time you have to do.
Okay, sir. Sir, another from my side, when we are mostly talking about the PPI, so where is the position of H2 receptor antagonist? And should we write or no?
That is the final common pathway.
Sir.
PPI is the proton pump inhibitor blocker. There's a final common pathway for hydrochloric acid secretion. Right. Whereas
yes, sir. So
histaminic receptor or muscarinic receptor, or gastrin receptor, the 3 other receptors are actually upregulate hydrochloric acid secretions. Right. So even if you give a H2 blocker, it will not be effective if you have 2 blocker because PPI duration is about 12 hours. Right. You can give H2 blockers after the PPI duration is over, when you are de-escalating it. But simultaneously giving it is probably useless.
Yes. Professor Anand, sir, another one more suggestion. You told that about the long duration of PPIs. So can we use antihistaminics for long duration instead of PPIs like NSAID-induced or the smokers who are having long-standing symptoms? Can we prefer in both ways to reduce the side effects and to reduce the cost? Can we go for H2 receptor now?
Yes, we can do that. Can you hear me? My light went off, so now I switched off to the laptop.
Okay.
So, yes, as it was mentioned by Akash Shukla also, when you are trying to treat the patient, usually a 2-dose PPI is required. In that case, H2 receptor antagonist comes in only as a de-escalation. If there is only if the patient of PPI, single dose PPI is not working and the patient still has mild symptoms, you can add a PPI in the night. That will augment the effect of PPI. But if the patient was on double dose PPI, that is, he was taking 1 PPI in the morning and 1 PPI in the evening, then best is to start with de-escalation in form of reducing it to once a day. If once a day causes symptoms, then possibly you can add H2 receptor antagonist. If it does not cause symptoms, then even that once a day dose can be replaced by a H2 receptor antagonist. Subsequently, we can reduce the H2 receptor antagonist to once a day and even alternate days, or even ad lib can be given. That is, whenever the symptoms occur, you can take it for 2-3 days and then stop.
Thank you, sir. I think, sir, we have done a good discussion as well. We answered all the queries. So I'll request our another moderator, Professor Akash Shukla, to have a few words and also he will suggest some. He has some thoughts about this GLAD, how to go for. So, Professor Akash, please.
So I think what I'm very happy with how things have gone so far, and I think the messages have been very loud and clear, and really want to congratulate Professor Anand and Dr. Ashok for this. I think one thing which we need to take a feedback on is when where these the end users are there, and they're having the discussion with the local expert. We need to find out whether they are doing whether they are getting benefited or not. I think that is the ground level feedback which we need to really take. And I think at times when we discuss among ourselves, we really try to discuss things which are of very, I would say, tertiary level care. So we should restrict our discussions to what will be available to every single person in the country, and even at district places and taluka places where we don't have gastroenterologists and we have only physicians managing these patients. So what should they be doing? So I think that is a focus which we should never lose, and we have to constantly remind ourselves, because we are not used to talking at that level quite often. So I think that would be my feedback. So we keep on reminding ourselves and all the speakers and all the panelists that we have to sort of keep that level of discussion.
Thank you, sir. So last time we have started a survey about the questions that needs to be the real concern, as you rightly said. So that is feedback is after that, and we thought that also in addition to that we can get the questions. I think this time because of we are not able to get the questions, but we request to all whoever is attending this webinars. So next session will be very interesting one. It is on 26th of August. It is on alcohol and the liver, and which is the most common thing you can say. And Professor Akash Shukla is going to have the speaker for this session in 4th week of August, 26th of August. And the topic will be alcohol and the liver. And hopefully I'll request Professor Akash to have a, as he rightly always suggesting, to have basic primary level presentation. And also I'll request to get questions from you, sir. So we can make a survey on that, and we can give you that areas. These are the concerns of a general practitioner, so that can become also more focused and more problem oriented. So this is what we can say. And third, we have the editorial board with the issues to be coming up. And Professor Y.K. Chawla is our editor-in-chief. And I'll request Dr. Akash, who has shown that the things should come regularly, and will come definitely to all our audiences with our newsletters, what we discuss, what will move forward very soon. So with this, I think we'll go to end of this session. And anything from our patron, Professor Subrat sir, then we can close this. Professor Acharya sir.
No, thank you very much. I must congratulate you all for this laudable efforts. And well, continue this and continue the newsletter. That's very important. And circulate it. And that will be very more informative in print, what you are saying. If it is in print and people get it, that will be very important. I will suggest the format of the newsletter should be in bullet points. Instead of writing in detailed print, you must understand the psyche of people. And you are addressing to the physician who are very busy at the field. So that should be bullet, right? Instead of very detailed descriptions. And that should be a distinctive features of this newsletter, right? Which will be easy, readable, attractive, and do not contain a lot of print details, which you and I know are many times very difficult to go through, right? And that's is a very important way to transmit your message across to the ground level. Thank you very much. And good
Thank you, sir. Yeah, good night, everyone, sir. We'll close the session today. Thank
Good
you.
night.
Thank you. Akash. Akash.